York. And we are really honored and happy to greet our second keynote speaker, Kadija Ferryman. Kadija is a cultural anthropologist, and after a bachelor's degree, she did policy work for some time, mainly related to housing, and then received her PhD at the New School, and is, as you can read, the industry assistant professor at the New York University, but also Mozilla Open Science Fellow and affiliated with the Center for Critical Race and Digital Studies. So you already see that she's one of these people who are able to tie together perspectives, theory and practice, policy and research, and different fields of thought. What I found interesting is that during the last 3 days, basically, we all refer to data as the new gold or oil, and this metaphor should stop us in our tracks when we realize what oil means for a global society. And Kadija has another suggestion. Should we imagine, she wrote, referring to Marcel Mauss, data as a gift, a product and driver of social relationships, and what kind of technology would we need for this? So today she will talk about precision medicine, about equity, ethics, and policy. So welcome, Kadija. We are glad to be able to hear your talk.
Thank you so much, Regina, for that introduction. Sometimes I think about the different fields that I've been in and that I continue to engage with, but I like the way you put it, sort of connecting theory and practice and research and policy, and that is what I try to do with my work, try to do with my research. So thank you for that very generous introduction. And I'm happy to be here with all of you. And today I'm going to share a little bit about the research that I have conducted, as well as share with you all some of my current research, so kind of research that I've conducted before, how that connects to some current research, and also some future directions for my research that I believe we have time for Q&A, so I hope that there will be some time to really engage with all of you and get some of your thoughts on how you see connections between this work, how it ties together, and where some of the interesting directions might be. So I think if we can have an exchange in the Q&A time, that would be great. Okay, so I gave a little bit of an outline of the talk, but let me, but let me just do it a bit more specifically. So what I'm going to do first, because I am talking about precision medicine, and this is a term that may not be familiar, or if you are familiar with the term, we may have different conceptions of what precision medicine is. So I'm going to start out with a bit of a conceptual history of the term precision medicine, and with my conception of precision medicine. Then I'll talk about the Fairness in Precision Medicine research project, which is a project that I did when I was at the Data and Society Research Institute that informed my current and my future work. I'll talk about the approach and methods of that project, some of the findings and implications, and then I'll go to sort of how I see my research program. And I think about it really as, how can we center equity in precision medicine? So how could we center equity when we're in precision medicine when we're thinking about ethics? How can we center equity in precision medicine when we're thinking about politics? And so I'll share some of the current work that I've done towards that end, towards that ethics and policy towards those ethics and policy ends. And then I'll talk a little bit also about my future research. Okay, so what is precision medicine? That's one place we can start. So I'll start our journey together with the idea of precision, with precision medicine. So in somewhat simple terms, precision medicine can be understood as using big data such as genomics, electronic medical records, wearables, and other data sources together with advanced computational tools to identify risks, risk factors or characteristics that relate to health and disease. But how did we get to this somewhat simple definition of what precision medicine is? So before there was precision medicine, there was this idea of personalized medicine. And this image here of, it's a comic from, I believe it was from the New Yorker, over a decade ago, shows a woman going into a pharmacy and saying, you know, here's my DNA sequence. And you can see in this image, the pharmacist is sort of overloaded with multiple drugs, and the idea or the implied idea is that as she's handing the sequence, she'll get back a kind of personalized drug for her specific DNA sequence. And so this was the sort of prevailing idea of personalized medicine. And this idea of personalized medicine was really one of the hopes of the Human Genome Project, the major scientific effort that resulted in the sequencing of the entire human genome. And this was really the hope, that one of the hopes of this sequencing project, that we would one day be able to walk into a pharmacy with our DNA sequences and receive personalized medications. But then in 2011, the national academies in the US shifted the kind of rhetorical grounds from personalized to precision medicine. So this is at around 2011 in the US is when we see the emergence and a sort of shift from this idea of personalized medicine to precision medicine. And part of how this shift occurred was through this report that the National Academies published in 2011. And this was a significant moment, sort of inaugurating, some point to this as the kind of inauguration of the term precision medicine, and as the preferred term to describe medical care that would be based on this new biological information that we were discovering, genomics and other kinds of new information. And in this report, the authors took care to assert that precision medicine, though it would be informed by individual biology, it did not mean that every individual would receive different treatments, would receive different medicines. So it really was, again, this kind of conceptual break between this image of personalized medicine that was illustrated by that cartoon. So we see a different kind of idea of precision medicine that was illustrated in the cartoon. And so it's not that individuals would receive their own bespoke care, but that biological information, other kinds of health data would help to make medical care more relevant and more effective for individuals. So there still was this idea of tailoring that remained in this concept of precision medicine, as well as this idea of medicine being more efficient due to more data. And another important part of this conceptual development of precision medicine is Barack Obama. And so although he may be more often remembered for the Affordable Health Care Act, one of President Obama's most significant achievements in the realm of health was launching the Precision Medicine Initiative in 2015. This initiative began with a $215 million investment by the US government that has increased by increased by 60 million in later fiscal budgets. And he described precision medicine as an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. And he explained that in order to achieve precision medicine in the clinic, we must fund research. So, so again, there are some additional distinctions between even from 2011 and the National Academy's redefining of what precision medicine is to then Barack Obama's conceptualization of precision medicine in 2015 with the launching of the Precision Medicine Initiative. One thing we see here is that genes, in addition to genomic data, even though he has an image of a DNA double helix here, he's very clear in this definition that precision medicine includes not just genetic data, but also other data like environment and lifestyle data. And he also is very clear, because of the launching of the Precision Medicine Initiative that includes research, he makes this connection within the definition of precision medicine between research and clinical care, so that in order to have this precision medicine of the future, what we might think what it should be, again, this tailoring, including multiple aspects of a person's biology and environment, we also need to do research to make sure that happens. So as it happens, also during this time, during 2015, during the launch of the Precision Medicine Initiative, it also sort of coincided with the ever increasing variability of digital health data in addition to genomic data. So in the United States in 2009, there was the launching, another thing that Barack Obama did was sign into law the High Tech Act, which funded the move from paper medical records to digital health records. So within less than 10 years, you have this complete changeover from paper health information to digital health data. So there was this new form of electronic medical records data that hadn't been previously available. Also, what we can think of as Internet of Medical Things devices, again, were also during this time being rapidly developed. So we can think of Internet of Medical Things as devices that were health devices that were wirelessly enabled. So wireless glucose monitors, wireless blood pressure monitors, things like that. We can also see during this time the rise of mobile apps, including health apps that are also providing new sources of data in addition to genetic data. So there's really more health data that's available to be used. So we can imagine that in that definition, in that more expanded definition that he gave in 2015 of precision medicine, that it's including these other kinds of health data. And in addition to expanding the sort of idea of health data and what health data will be included in precision medicine, as I said, there was also a refinement of precision medicine's approaches. And so we can think about precision medicine having three kinds of approaches. One is to predict risk. Another aim of precision medicine is to diagnose or detect disease. And another aim of precision medicine is to treat disease. And so these, of course, are very familiar categories when we're thinking of medical intervention in general. However, when we start thinking about, as I will talk about later, about precision medicine, especially as it relates to inequity, it's important to keep these different distinctions, these different approaches in mind. And along with differences in, or kind of expanding in the kinds of data that's included in precision medicine, disaggregating the kinds of approaches that precision medicine will take, I also want to sort of point to the promises of precision medicine that, again, were emphasized in the National Institutes of Health when they launched the Precision Medicine Initiative. And this was also expressed in Barack Obama's opening speech and in the documents that were produced by the Precision Medicine Initiative later. So this NIH's effort emphasized the promises of precision medicine, including better medical care and ultimately better health outcomes, reductions in healthcare costs because treatment would be more tailored, as well as empowerment of individuals through engagement with their own health data, such as through patient-facing portals and electronic health records, and the contribution of individuals being able to contribute their own health data, such as through these new mobile and digital technologies. So this was also the sort of promissory aspect of precision medicine that we see discussed in the NIH's documents about this new initiative. So just to bring together this conceptual development from personalized to precision, a couple of points to highlight: that there is this focus on data, specifically multiple forms of data. So again, when personalized medicine was really focused on genetic data only, so in precision medicine, there was this focus on multiple forms of data. And then there's also in precision medicine this focus on patterns, risk profiles, patterns, risk profiles, and risk groups that could be developed using data analytics. In addition, in precision medicine, and due to the sort of launch of the Precision Medicine Initiative that included the building of the All of Us research program that was essentially the building of a large health data infrastructure, we see in precision medicine this focus on building large health data infrastructures and new knowledge networks, as Francis Collins, the head of the NIH, described them. So what are the implications of this conceptual development? So there are a few things to note. So one, we can think about this move from personalized to precision medicine, sort of bridging the gap between the idea of personalized genomic medicine, again, as illustrated in the cartoon, and public health. So initially, again, when the Human Genome Project was getting started, and there was discussions about what kind of health implications there would be of the Human Genome Project, this idea of personalized medicine, there was some criticism of, again, if we think about that image from the cartoon of people being able to go in and get personalized medicine based on their genomic sequence, there was some criticism of that approach from multiple fields, specifically from public health, that said, well, you know, this focus, should the future of medicine just be on individual health and individuals' risk factors for health? Because we have, you know, for public health, the focus is not on individuals, the focus is on groups, and the focus is also looking at what are group level and structural risk factors that impact health. And so with the move from personalized medicine to precision medicine, as again, as outlined, especially when we get to the NIH definition, that includes not just individual data, but environmental data, other kinds of data, thinking about how you can use data, how people can use data to empower themselves, to get to better health outcomes, how the data can be analyzed to save money, and also, again, potentially improve health outcomes. We can think of this expanded definition, or this expanded concept of precision medicine, bringing together what had been a large schism between this idea of individualized personalized medicine and public health. So the gap is still not completely closed, but there is we see more of a bridge with this kind of definition of precision medicine. We also see that the bringing together these other kinds of data, not just genetic data, really puts in the forefront the importance of ensuring that big health data is inclusive. So there were some hopes that, you know, with getting, with precision medicine being able to bring in things like environmental data, that there could, again, be a way to bring in other factors that influence health in the analysis, in the analysis of health data for precision medicine. But another important implication, or another sort of issue that this expanded definition raises, is that with bringing together all of these different kinds of data, yes, they can perhaps be more informative than just genetic data, but this raises new questions of privacy and security implications when bringing together these different and disparate kinds of health data. Again, in that launch for the Precision Medicine Initiative and in various documents related to the initiative, there's this emphasis on empowerment, this emphasis on the ways that building precision medicine databases will allow people to really be able to get closer to their health data and use it to inform themselves and improve their health. But another way to think about that empowerment is that it creates a new responsibility for individuals to be knowledgeable about their data and to take preventative action. So we see sort of the flip side of empowerment through precision medicine to be new responsibility and new expectations for individuals to really, again, sort of take charge of their health, be as scholar Vetker has called people to be data managers, to be managers of their own health data. And that, when we think about these kind of new responsibilities and expectations, those have important implications, especially when we begin to consider health equity. It's also important to sort of think about in this expanded definition of precision medicine, what other implications are left out. So one thing that was not sort of emphasized in some of the promises, or in some of the promises and some of the ways precision medicine was discussed, is how some groups might be unintentionally or invisibly harmed by these data initiatives. So I shared in the previous slide the hopes for precision medicine, the promises of precision medicine, but it's really important to also ask this kind of question to say, how might some be harmed, left out in ways that are unintentional, or perhaps invisible by this kind of data initiative, by these kinds of data initiatives. And what was interesting about precision medicine is that, as I said, we saw the launch in 2018 and it really kind of getting off the ground after that. And I showed the slide from the Precision Medicine Initiative that is funded by the National Institutes of Health. But at the same time, there were other precision medicine research projects kind of getting off the ground that I'll talk about as well. And so although there was increasing investment activity in precision medicine, and framing it really as a big health data kind of project, these kinds of questions, particularly this question, was being asked in other big data projects and other fields that were taking shape. So big data and how it was being used in criminal justice, for example. We saw during that same time those kinds of questions being asked by scholars and others, and raised in relationship to big data projects. But at this time, there were we didn't see these kinds of questions being asked in relation to big health data. And the sort of lack of asking about these questions, or asking these kinds of questions, that doesn't mean that there weren't potential problems. And so these are a couple of problems or potential pitfalls that we can see when we're thinking about precision medicine and how some groups might be invisibly harmed. And actually, during this time, there were already some there was already some evidence that precision medicine, even in its very early stages, might not benefit all groups in the same way. So there was in the New England Journal of Medicine, there was an article showing that this article was called Thinking About Imprecise Medicine. There was research showing that that genomic researchers found that a group of Black people were being misdiagnosed as having a genetic risk for a heart condition, largely because the research sample did not include enough participants. So there was already evidence that personalized, the sort of idea of genetic or genomic medicine was not working the same for all groups. So we were already seeing some evidence even before we move into a big health data version of personalized medicine, that even when we just look at genomics and applying that to medicine, that there were already some problems afoot. And in another case here, this headline about Plavix, this is another case of a study that that was used to establish treatment guidelines for a blood thinner, and it was based on a study with a 95% white study population. And so as a result, the study failed to detect that people of Asian and Pacific Islander ancestry have a higher frequency of a genetic variant that impacts how they respond to this drug. So these were two concerning cases around this time that relied on genetic data, but begs the question of what kinds of problems could emerge when using multiple forms of data, such as in this new idea of precision medicine. And lack of inclusion, sort of not being included. So those two examples, the example of Plavix and the example of the heart condition, were the sort of dangers being suggested by certain groups not being included in certain kinds of health data. But it's also important to note that a lack of inclusion is not the only concern. And we saw these kinds of issues raised again by other researchers who were looking at the use of big data in other fields. So this is Kathy O'Neill's book, Weapons of Mass Destruction, and the ProPublica article that's that showed that software was being used to and risk prediction algorithms were biased against Black defendants. And so in these cases, it wasn't that there was a lack of representation of people of diverse groups, but actually even when there was, when people of diverse groups were included in databases, they were still biased, so that these problems that we were seeing emerging wouldn't just be fixed by making those genetic data sets, let's say, more representative, right? That even when people of different groups are included in these data sets and these big data projects, and we see computational tools like algorithms being used on them, we're still seeing bias emerge. So there's inclusion, yes, which is one problem, but also lack of inclusion is not the only problem as well. So with these things in mind and sort of thinking about these questions, in 2016, we launched the Fairness and Precision Medicine Project, because as I said, at that time, and the announcement, the PMI Precision Medicine Initiative was launched in 2015. And at that time, as I said, there weren't these kinds of questions being asked about the potential pitfalls for precision medicine. So in 2016, we decided to launch the study to begin to ask some of those kinds of questions. So this study was funded by the Robert Wood Johnson Foundation, started in October of 2016. And we examined precision medicine documents, conferences, press releases, and also mapped major precision medicine research projects to sort of learn about where was the significant research happening in precision medicine at that time, and did interviews with 21 experts and different stakeholders who were involved in precision medicine. And we talked to some researchers who were involved in various precision medicine research projects, We spoke to a few patients, we spoke to some software and some software developers as well who work with big health data. So this project, the Fairness in Precision Medicine project, was sort of informed by my own background, of course, as a cultural anthropologist. And when asking these kinds of questions, we really, again, sort of took our sort of theoretical grounding from a kind of critical medical anthropology approach. And how I think about critical medical anthropology is its commitment to holism, and thinking about how health and disease are influenced by multiple factors such as cultural and social context, politics, and economic conditions. In critical medical anthropology, there's a commitment to elevating the marginalized in the domain of health. So again, raising up and making central marginalized ways of thinking and knowing and disparate impacts on marginalized groups. So again, these questions around how could precision medicine affect groups differently? I really connected that to this aspect of critical medical anthropological approach. Critical medical anthropology also examines relations of power, implicit and explicit values in medicine and healthcare. So it was also really important, again, as I was mentioning before, sort of looking at this conceptual development from personalized to precision medicine to not only ask how certain groups might be impacted differently by these kinds of research projects, but what were the values that were being used to frame these kinds of projects, and again, how do those values serve or not serve all groups equally? And critical medical anthropology, of course, relies on multiple methods, including participant observation, ethnographic and in-depth interviewing, and content analysis. So even the sort of methodological approaches, we tried to bring some of those to the Fairness and Precision Medicine project. But our inquiry there was also informed by a science and technology studies approach. And for STS, again, the aspects of STS that were important to us as we were doing this project was sort of thinking about the relationships between human science and technology. And so, of course, precision medicine being this field of scientific research that is heavily dependent on these new and different forms of technology. Also examining how scientific facts and technologies come to be. So even the first part of the talk here of sort of tracing out the conceptual development of precision medicine is a kind of STS sort of intervention and a sort of STS analysis of how do we understand things sort of coming to be, as well as how we see scientific knowledge relating to the political, social, and economic climate. And what's also very important for me as an anthropologist who looks at technology, looks at the impacts of technology on different groups, is to make sure that I am keeping the technology itself central, right? So critical medical anthropology, similar to an STS sort of approach, there's overlaps, of course, right? So there's similarities in approach between an STS approach and a critical medical anthropology approach of looking at social context, putting scientific knowledge and social and cultural context together, looking at power relationships, looking at different sort of relationships. But where I really find an STS approach to be useful in addition to a critical medical anthropological approach is this focus on the kind of materiality of scientific equipment. Especially in STS, there's been a line of work in STS looking at what we think of as sort of invisible technological infrastructure and networks. So there's this kind of field of STS of infrastructure studies of technologies that are often in the background, but are of course very important. And so we thought about the building of precision medicine research projects as these infrastructures, and how they would sort of function, how are they functioning as infrastructures? Because just to give you a little bit of background on the NIH's precision medicine effort, it is not a research study with particular questions. It really is, the aim of that study is to enroll 1 million people, have them give their genomic data, other kinds of health data, submit their Fitbit data, for example, to collect these multiple forms of data that I talked about earlier, but then make that available to researchers and the public. So it really is this kind of data platform that the NIH wants to build, as opposed to, as I said, a research project with particular research questions. So I really did find it useful to think of this project, this PMI, Precision Medicine Initiative, and the All of Us Research Program as kind of building this sort of technological infrastructure. And if we thought about it as an infrastructure, you know, what kinds of questions would we be able to ask when we thought about it through that framework? So we found that to be helpful as well. Of course, the other helpful aspect of a science and technology studies approach is to think about the co-production of science and society. So this is the report that resulted from our research, and I did this study with a colleague of mine, Michaela Pitcan. And so I just want to share, again, some of the findings of the project. So first, we looked at a number of different precision medicine research programs. So we looked at the All of Us program, which is the NIH's program that is part of the Precision Medicine Initiative. We also looked at Project Baseline, which is a precision medicine research, very similar in some ways to the All of Us research program, in that it is building of a data platform. But Project Baseline is funded by, or is sponsored by Verily, which is part of the Alphabet series of companies, and Alphabet is of course the parent company of Google. So Project Baseline is an effort from the private industry or from the private sector. So we have the All of Us research program, a sort of big national government initiative. We also looked at Project Baseline, this private industry precision medicine initiative, and the Human Project at NYU, which was a smaller scale and academic effort centered at NYU, at New York University, and this project has now actually been paused since we did our study. But we wanted to also compare it with an academic project that was on a smaller scale. The Human Project was just focusing on New York City. So All of Us and Project Baseline are national, and the Human Project was just based on the New York City geographical area. And this is one of the things you maybe can't make this out, but we did also create a mapping of these precision medicine research projects, because we wanted to see how they were all connected. And even though you can't make out some of the names here, I think what you can hopefully get from this image is how these studies, as we did more research into them, these precision medicine projects, were really connected to multiple institutions. And even though the All of Us research program was a government project and Baseline was a private industry project, there were actually private and still are private industry actors and players in the All of Us research program, and academic players in the Baseline, et cetera. So there were some interesting, it was just interesting to see the number of different organizations involved, as well as the different kinds of organizations that were involved. And like I said, I apologize for this not being completely clear on the slide, but I will say that our report, this Fairness and Precision Medicine report is available on the Data and Society website, so you can download it and see the better picture there. So a little bit more about our approach in doing this research. So fairness was a key term, and we defined it broadly as the best possible outcomes for everyone. And we also wanted to ask about bias. And again, we provided or thought about it in a very broad way, such as any tendency that prevents unprejudiced consideration of a question. But really, we actually asked our respondents in our interviews to define these terms in the ways that they saw fit. So we actually wanted to hear from them how they thought about fairness and bias. So the findings of the study are sort of in two buckets, if you will. One is bias that was in data sets and sort of analysis processes. And there was another set of findings on the potential discriminatory outcomes of precision medicine. And so I'll explain more what I mean by these two sets of findings. So in the first set of findings, bias in data sets and analyses, there was an example that one of our respondents gave us that I think really illustrates some key aspects of bias and potential pitfalls of bias in data collection and analysis for precision medicine. And he gave us this example of African Americans in the US not qualifying for lung cancer screening. So he was sort of telling us, because he does work in the community, he was a clinical researcher, and he essentially said that when the sort of research that was being done to develop the lung cancer screening guidelines, people were asked if they smoke, how much they smoke. And the guidelines were around, a pack of, if you smoke a pack a day, then that really increases your chance for developing lung cancer. And so that is sort of the cutoff for getting early screening for lung cancer prevention. And he says, even that study to determine the baseline for lung cancer screening, he believes was biased against African Americans because of kind of cultural factors that have to do with smoking habits in African American communities in the US. And he mentioned to us that many, not all, but often African Americans who smoke menthol cigarettes. And if you smoke menthol cigarettes, you don't smoke a pack a day if you're smoking menthol cigarettes, because those are kind of stronger. So you actually, if you were asked how much do you smoke, and if you are smoking menthols, you maybe wouldn't say that you smoke a pack a day, but you would still, because those cigarettes, still are quite damaging, you would still have kind of damage to your lungs, but wouldn't necessarily qualify for a lung cancer screening if that's the question that was asked. So he says he sees the sort of cascading results of that when kind of cultural differences in smoking habits weren't taken into consideration, you have the establishment of a guideline of do you smoke a pack a day or more or not, and that starts to funnel people into getting screening. He says, well, when he does lung cancer screening in his community, he sees that, most people don't qualify because they don't have that screening history. They don't answer, yes to smoking a pack a day, but of course, they are still experiencing lung cancer. And what happens is, he says, they, because they're not able to be screened earlier, there are cascading health impacts. And we saw evidence of this kind of story that he told us is confirmed by recent research that shows that African Americans have a higher chance of developing lung cancer, even with fewer pack years of smoking than white smokers. So again, kind of confirms the story that he told us about cultural differences in kinds of smoking habits between menthol cigarettes and non-menthol cigarettes, and how this is important to this kind of story about lung cancer screening and menthol cigarettes. How does this relate to precision medicine and the potential for bias in a big health data platform? Well, one could speculate, based on data, if you were to look in clinical data and see this difference, right, that African Americans have a higher chance of developing lung cancer, even with fewer pack years of smoking, that there's some kind of biological or genetic vulnerability because this group has a higher risk of cancer with less smoking. But you would only kind of jump to making that kind of biological or genetic explanation if you didn't know the historical context of the data, if you didn't understand that the reason why when you look at clinical data and you see African Americans with higher rates of cancer, even though they're smoking less, it's missing that there was something missed there in screening, right? That maybe if this group had actually gotten screening, and if the research had considered some of these cultural differences, maybe screening rates would have been different, and then maybe those rates of developing lung cancer would have been different. So this is the kind of bias that is embedded in health data. But again, if you just look at kind of population percentages, of lung cancer incidence, but don't know some of this deep history and this deep context that our interviewee shared with us, you could really interpret that data in very different ways, or you could, and then, potentially build analysis tools on top of that data that would tell you different things without that context being there. Another one of our interviewees who was a software developer told us, who works with health data and builds health data algorithms, mentioned that sometimes one of the biggest challenges in doing his kind of work is that as a data scientist, as a software developer, that he's missing that data history and context, or as he called it, the data empathy. He said, I don't have, sometimes for the data that I work with, I don't have data empathy. I don't know where it came from, what it means. I don't know the history and the background of it. And so I'm using it and using this data to build different kinds of models and things like that, but I'm doing that without this data empathy. Again, to kind of illustrate this point of the importance of data context and history, and again, how this anecdote from our interviewee really connects to other things that we see in research. In 2008, historian of science Lundy Braun wrote this book, Breathing Race into the Machine, that really identified that there is it had always been kind of known, but didn't bring into the forefront the history of why there is a race correction in the spirometer. And the spirometer is a tool that's used to measure lung capacity. And in the US, I'm not sure about in other places, but in the US, when someone breathes into the spirometer, there is that reading is then corrected with different racial weights, essentially. So there is a correction built in if you are African American, and there's a correction built in if you are Asian. So for Asian and African American patients who breathe into this spirometer, if that's how their race is identified, it's that measurement is changed, and it's from this idea that this medical belief that African Americans and Asians have lower lung capacities. And in this book, which I encourage you all to read, she does a really good job sort of tracing the history of that belief of African Americans and Asians having lower lung capacity, and she sort of connects it to histories of plantation slavery, and really asks us to bring this to question this assumption, and also tells us that this correction is often invisibly built into spirometer devices, so that clinicians or patients don't know that this correction is being made for them. And she also talks about some of the impacts of that kind of racial correction when there's things like employment tests that depend on lung function and things like that. And there has also been some questioning of this idea of other racial correction. So there's a racial correction for the eGFR measure, which is a measure that's used for kidney function. And this was something that, again, was a correction that is being kind of questioned. And this was in 2008. This article was published, I believe, in 2011. But we didn't really actually see much attention to how much of this kind of data context and history, especially around why clinical data might have some embedded biases that we don't even see, that are invisible to us until just this past year. So in 20, I believe this article was published in 2020. This was the first kind of comprehensive article that pulled together all of the different racial corrections that are used in clinical algorithms, and really asked us to consider and question the basis for these racial corrections. So I'll just share with you some of the excerpts from the tables that were included. We see that there are racial corrections used in oncology, for breast cancer risk. You see that there are for certain of these algorithms, that the risk calculation, there's adjustments made for African Americans, for Latinas, for Asians. And again, part of the goal of this kind of study was to say, let's think, and when they looked at when they pulled these racial corrections together, the one point of it was to say, look at all of the racial corrections that occur in clinical practice that, again, may be invisible to many clinicians and to many patients as well, but also the rationales for these clinical corrections are often different. So there's sometimes it's for supposed biological factors, sometimes it's for kind of some social factors that are mixed in with the biological factors, and also the, when let's have a reconsideration of the research that was done to inform these racial corrections. And the other point of this kind of article and bringing up questioning the idea of racial correction is to really think about it also as a matter of justice. So the American Heart Association, for example, has a heart failure risk score that assigns 3 additional points to any patient that's identified as non-Black, thereby categorizing all Black patients as being at a lower risk. And in this case, there isn't actually a rationale for this adjustment. And the important point here and why this becomes a matter of justice is that Black is equated due to this calculator with lower risk, and following the guidelines could direct care away from Black patients. So the example from our respondent, these examples that I've given of racial correction are intended to sort of, again, bring to the forefront that clinical data itself may have these embedded biases in there that, again, you have to know without knowing the context and the background. Once these data are being collected in large data platforms and analyzed in different ways without knowing some of that context and background, we can get into some potentially dangerous areas. But just recently, that article that was published has had some effect. So at least one hospital in the US has decided that they will not use the racial correction for kidney function anymore. And even though this is a big win, and this is a tweet, another researcher brings up the idea that, okay, well, that's great that hospitals won't use this, but again, what about the technologies that are built upon health data? So this researcher here replies and says, well, what about health apps that are using clinical data? Are they going to remove these race-based corrections from their weights? And it's an important question to ask, because we see, if in the App Store, for example, there are many of these health apps that use these similar risk prediction algorithms as part of their apps that are drawing from these clinical data and using these same clinical corrections that have these race corrections built in. And again, would be invisible to you if you did not know this background, that when you download this app, that kind of in the background, there are these different corrections being made for your risk. And there are just multiple of these kinds of apps. So another example of the kinds of risks in data collection and analysis that we highlighted from our project is also during the process of labeling and then modeling clinical data. So I spoke with, as I said, a few, my partner Michaela and I, we spoke with a few software developers, people who work with health data. And one of the questions I asked one of our respondents was, well, how much, when you're building these models using clinical data, how much negotiation is there between what is on the actual electronic medical record and the labels that you use to build your model? And I'll kind of summarize here what our respondent said. And he said, well, for some labels, it's pretty much the same. He said, for others, it's more complicated, because when we're looking at the electronic medical record, there isn't, as he says, there isn't just one place in that record that says someone is diabetic. They're being prescribed anti-diabetic medications, they're getting diagnoses, they have a lab value. So there isn't just one thing. You have to look across the label to find, the information that you're looking at that tells you if that person is diabetic. And so what he says and what he sort of points to is that he says, so what we do is we kind of make decisions ourselves based on that clinical data, what we are going to use as the informative information about someone's diabetic status. And he said that sometimes they bring in clinicians and help, and other times it's the software analysis teams that make these kinds of decisions. So you can imagine there that that could be another potential for bias creeping in when you have people sometimes from a clinical background, sometimes not from a clinical background, making decisions and really interpreting what clinical data mean for these health data algorithms that they are building, and then the technologies that use these algorithms. So it's important to, again, when thinking about these potential pitfalls, to think about how the sort of different steps that health data has to go through. It has to be cleaned, it has to be interpreted, it has to be standardized, so that this electronic medical record data can be used for models. And the key point here is that this data is not objective, because we see some of the other with the examples of racial corrections and all of these kinds of corrections that are with and biases that are embedded within clinical data, that they're not objective, and that they reflect the values and decisions of those doing the interpreting, labeling, and building of health data models. So electronic health data was one of the particularly problematic when we were thinking about precision medicine as this big health data initiative, one of the particularly problematic areas of particularly problematic kinds of health data. Okay, and how am I doing on time? Sorry, I haven't been keeping track. How much more time do we have?
Maybe around 10 minutes or so.
Okay, all right, thank you. So I'm gonna just zip through the next couple of slides. So the last set of findings was sort of thinking about, so I talked about the potential for data bias in this whole process of data cleaning and analysis. But we also thought about, and it emerged in our study, is that even if data were to be perfect, let's imagine this future of precision medicine where there's these multiple kinds of data being used to inform healthcare. Even if the data were perfect, would precision medicine still have equal impacts across different groups? And we realized that that was not the case. So one of the things that came out was that even if the data were perfect, this idea of having more discrete data on people's health risks could be used against them to limit what kinds of resources they could have access to. And we see this sort of echoed in the comments about the precision medicine initiative. There really was this kind of value statement that there's the expectation that ultimately we want every American ultimately to be able to access and analyze their own health data so that they can make the best decisions for themselves and for their families. And so we can think about, will everyone be able to take up this responsibility in the same way, right? So if this is the expectation ultimately for everyone in America, and what needs to be in place in order to do this, in order for everyone to be able to access and analyze their own health data and make the best decision for themselves, and who might be harmed by this kind of expectation. So I just want to go over, sort of summarize our findings, sort of helped us create this framework of how we can think about algorithmic bias in precision medicine, but who is missing or underrepresented in the data, how individuals and groups are represented in the data, how the data is cleaned and analyzed and by whom, and which labels are used in models, as well as the disproportionate impacts of these models. And so after the report, this research was published, I wrote a couple of, wrote this opinion piece with a physician saying, let's think about how AI, which is used in precision medicine, can entrench health disparities. So what are the, what do we need to do? We need to address algorithmic bias in order to address health equity. We need to prioritize health equity in medicine. We need to capture kind of multiple kinds of data. And we also need to consider that maybe when we're thinking about health equity and this sort of future of precision medicine, maybe there are, non-technical, non-AI possibilities that could be just as effective. So this last line we have here, that it may be more effective to invest in low-tech interventions that may not be as slick and attractive as these new technologies, but maybe just as effective. And so since that work was published, there's actually been a really encouraging increase of attention looking at the connection between data bias, algorithmic bias, and healthcare. So where earlier there weren't these questions being asked about these kind of disparity and equity questions being asked about big health data, being asked about precision medicine, there is a lot of research being done on this now. So one of my colleagues, Marcia Gassimi, she's done some great work looking at really uncovering some of the biases in clinical data. So for example, this is just an excerpt from a topic research that she did that shows that when you look at clinicians' notes around mental health, there are differences by groups and even how mental health is discussed. So for example, white patients had higher topic enrichment values for anxiety and more chronic pain topics, where Black, Hispanic, and Asian patients had higher topic enrichment values for psychosis. So again, how mental health was talked about in clinicians' notes was different. There was a New York Times op-ed just in 2019 pointing out this idea that AI, again, instead of it being this kind of hope for the future, could worsen health disparities. And of course, there is this kind of well-known article now, the Obermeyer article, that shows that an algorithm that was being used to help manage health resources was biased against white patients. And this was, again, in 2019. So if we've kind of gotten to a good place where we have realized that there are problems here, we sort of answered the question of, is precision medicine fair to all groups? No. What do we do about it? How do we get from fairness? How do we move from asking about fairness to equity? And can we really harness the power of health data for equity? That's one of the main questions. So to this kind of last part of the talk, where I'm going into some of my current work around looking at ethics questions and looking at policy questions. So one of the things that I did was really analyze, because I do have a policy research background, was analyze, I've been analyzing the kind of growing policy and regulatory environment for precision medicine, for AI tools in health. And so the FDA, which is the agency in the United States that regulates medical devices, they have been essentially grappling with how to regulate the use of AI, which handles big health data in health. And so they proposed a kind of set of practices and a regulatory pathway. But this regulatory pathway, in my view, did not really address health equity. It did not center health equity. So, and you can see in some of these, in the arrows with the italicized areas, that at all levels of the process, I essentially propose that there needs to be more knowledge of health equity. So again, when thinking about, so for example, one of the ways that the FDA sort of assesses medical device makers is they start with their culture of quality and organizational excellence. And my intervention is to say, well, in addition to their culture of quality, do they know that health disparities exist in the area that they are building their algorithm about? When they're making decisions, it's not just about how to validate the model, but how different decisions on how you would calibrate that model might have different impacts for different groups. That should be something that's very central and key, and that the FDA should require as part of good machine learning practices. And again, when they're selecting their data, have they done this kind of analyses of are there embedded biases in the data? Are there racial corrections? Have those data already been corrected for race in some ways that you haven't considered? So that should be part of good machine learning practices. And then finally, when these models are developed and used in the world, there's a requirement for real world performance monitoring, but that should also include a health equity review. So not just monitoring whether these models are performing accurately and predicting risk accurately, but is it really having an impact on these health differences that we see? And then the other, oh, I did have those circled, sorry about that. So the other current work that I've done with another group of colleagues is sort of in this previous slide that was directed to the FDA and the kind of policy regulatory field. But this article that came out a few months ago, we were really directing this to machine learning developers, so people who are working on developing these kind of big data health projects. And if at all, again, at all points of this process, if they were to consider various ethical, if they were to hold kind of social justice as an ethical value key, how would that change the process of developing their model? So we have some examples of that in that paper. So just quickly, I'll kind of share with you some of the things that I'm thinking about in the future for my future research. And I'm thinking about it as health equity in the information age. So how can we kind of bring together this critical medical anthropological approach to conduct research on values of health data platforms and these technologies, these data-driven technologies that sort of tell us about health risk. So there's policy analysis, policy recommendations, also empirical studies of values in data. So critically examining the implicit and explicit values in precision medicine that might affect equity, such as efficiency, responsibility, inclusion, privacy, and a deeper dive into this data histories and context that I mentioned. And one example of how one might sort of take this approach and do some empirical research is, so Google recently, if you've heard about this, they sort of got in trouble for collecting millions of health records. And we can think about this again as an infrastructure kind of project. So if you were sort of to focus on infrastructure and health equity and precision medicine, you can open up a wider field of analysis about what this kind of example of Google collecting health information means. In the press, it was framed as this is a privacy issue. But if you come at it from an STS perspective, the issue is not so much is it privacy or not, but what happens, what kind of power asymmetries emerge when Google essentially is providing the pipes, provides the infrastructure for health data. And I believe that's actually where Google and some other tech companies really want to make an intervention in the health data space, is not to become clinical providers, is to actually be in control of the health data infrastructure. So just the last couple of points, other new directions, sort of thinking of a comparative study of different health data platforms, of course, the All of Us Research Program again, but Google Health, the Rockefeller Foundation also is building a precision health platform. And there are, again, the regulatory space is developing here. So I'm going to be doing more research into kind of how we can think about centering equity in policy. And there are already some bills and there's already some policy, but there's more opportunities here. And it's also, what's also, I think, encouraging for me is that there are funding possibilities for this work in the STS Directorate in the US. And it also kind of falls under this framework of ethical AI and responsible tech. So there are opportunities to get this kind of work funded. So just to conclude, I'll say what's really exciting, I think, about this work is that we really are standing on kind of the precipice of precision medicine. We're at this moment of kind of opportunity. But what I feel is that we have the opportunity to forge a future of health because we are still relatively early in the process where we can be very explicit about what kinds of values we want to see included in our future health, and how can we include values like diversity, inclusion, reciprocity, refusal even, and also equity. So I will stop there and say thank you and looking forward to discussion and